Thank you. Our next speaker is Dr. Vaughn from Children's Hospital Colorado, who will be presenting early outcomes of a myofascial repair technique for fetal myelomeningocele. Thanks.
Hello. Thank you to APSA as well as Drs. Castle and Carlisle for the opportunity to present our research. Our team has no relevant disclosures. Myelomeningocele, or MMC, and myeloschisis are both part of a spectrum of congenital neural tube defects. As the diagram on the right depicts, they are due to the incomplete closure of the neural tube during fetal development, with myeloschisis defined by the absence of a cystic component. They are associated with a wide range of postnatal deficits, including hydrocephalus, difficulty with or inability to ambulate, as well as urinary or bowel incontinence. The hydrocephalus that develops can ultimately require surgical treatment, including placement of a ventriculoperitoneal or VP shunt. The landmark MOMS trial demonstrated that fetal repair is associated with improved outcomes, including a significantly decreased need for postnatal VP shunt placement. Previous work has also suggested that a watertight fetal repair is requisite for the restoration of the normal flow of cerebrospinal fluid, and therefore leads to improvement in hindbrain herniation. It is then thought that the improved hindbrain herniation leads to decreased hydrocephalus postnatally, which is then responsible for the decreased need for VP shunt placement or other surgical management of hydrocephalus. Various techniques have been used in the fetal repair of MMC, although modifications in these closure techniques have not been extensively studied. Previously, a single-layer primary skin closure was used as the standard technique and if the defect was too large or irregularly shaped to allow for primary closure, a patch would be used to bridge this defect remaining in the skin. A new multi-layer closure technique was recently adopted at our institution and incorporates raising myofascial flaps to close the myofascial layer first over the dural repair, and then subsequently to close the skin on top of that. Again, primarily when possible, or if the defect remains too large, using a patch. We therefore hypothesized that a multi-layer myofascial closure technique would result in a decreased need for patch closure of the skin, improved rates of hindbrain herniation, and a decreased rate of surgically treated hydrocephalus. To evaluate this, we retrospectively reviewed all patients who underwent fetal repair of MMC or myeloschisis at Children's Hospital Colorado from 2013 through February of this year. We adopted the myofascial closure technique in July of 2019. So we therefore compared the outcomes between our historical non-myofascial repair group with procedures performed prior to July of 2019 to our myofascial repair group with procedures performed after July of 2019. We found that the myofascial repair group was significantly less likely to require a patch for skin closure, with only 15% requiring a patch in the myofascial repair group as compared to about 59% in the non-myofascial repair group. Additionally, we found that myofascial repair is associated with a significantly increased rate of improvement in hindbrain herniation on 2-week postoperative fetal MRI, with 94% showing improvement in the myofascial repair group as compared to 66% in the non-myofascial repair group. Of the 82 patients that had reached 12 months of age and had full follow-up data available at the time of our analysis, 62 were in the non-myofascial repair group and 20 in the myofascial repair group. In evaluating the rate of hydrocephalus requiring surgical treatment in these groups, we found a lower rate in the myofascial repair group at 25% compared to 42% in the non-myofascial repair group. However, this did not reach statistical significance. In conclusion, we found that the myofascial closure technique is associated with significantly decreased need for patch closure of the skin, increased improvement in hindbrain herniation, and shows promise to decrease the need for postnatal surgical treatment of hydrocephalus. These results therefore support a surgical approach that employs a multi-layer watertight closure. Future direction of this research will include evaluation of motor and developmental outcomes longitudinally, as well as continued evaluation of our patients who undergo this technique for repair. I'd like to thank the following individuals, departments, and institutions for making this research possible. I can now take any questions.
Thank you. Let's start with questions.
Hi, Diana Farmer from Sacramento. Congratulations on this great work and nicely presented. I think there has not been enough work on the detail of the closure in these patients, and there was a lot of variability even in the mom's study because the focus was on other things like maternal outcome to a certain extent. You didn't mention anything about the dura repair, which I assume they all had dural repairs, but sometimes people use a dural patch if there's inadequate actual dura, so just wanted you to sort of answer that question. And then, do you have any early information on any salutary potential effects on the motor outcome for these patients as well? Thank you.
Yeah, thank you so much for your questions. Regarding the dural repair, actually all of the patients in our cohort, except for I believe 2, had just a dural patch, the DuraGen patch, placed for the strategy for dural repair. We did as well evaluate multiple other kind of outcomes between the 2 groups, the non-myofascial and myofascial repair group, with regard to gestational age at the time of repair, gestational age at the time of delivery, operative times, blood loss, et cetera. And overall found that the groups were very comparable, with the exception of operative time being about 15 minutes longer in the myofascial repair group. And anecdotally, in following up with these families at the year mark, a lot of the parents have shown, they've been very pleased with the motor development of their children, but we have not officially performed the analysis and official data collection on the motor and developmental outcomes yet.
Great, next question.
Thanks. Laura Galgansky, Cincinnati. You commented briefly, but I was just wondering on your outcomes in terms of your gestational age at delivery and also other complications like inclusion cysts.
Yeah, absolutely, thank you. So gestational age at delivery was right about 32 weeks in both groups with no statistically significant difference. We did not find any difference in maternal blood loss between the 2 groups. Fetal blood loss was found to be minimal in all cases in the myofascial repair group, and no statistically significant difference between the 2 groups. We also looked at lesion level, the size of the defect going in, pre-operative as well as post-operative, lateral ventricle size, which they were all comparable between the 2 groups. And then, of course, tracking perinatal deaths, which we've seen 3 total in both the non-myofascial and the myofascial repair groups, all of which were due to extreme premature delivery around 24 to 25 weeks after PPROM and development of chorioamnionitis.
Great, thank you. We'll take one final question.
Yeah, I'm from Tokyo. Thank you very much for a nice presentation. Have you specifically checked the neurogenic bladder function between the 2 groups? I mean, the first year group is better than the other group in terms of the function of the bladder or function of bowel function.
We have not yet. It is absolutely one of the future directions of things we're planning to analyze.
Thank you.
Thank you.
Okay, well, great work. We'll clearly look forward to your follow-up studies.
Thank you so much.